hope you like that music better. It sounded a lot better to me this time. Today we're going to be talking about heart attacks in women. You may or may not know, YouTube is predominantly a male media. And guess what? If you look at our viewership, subscribers, it's about almost 90% male. So I haven't really focused a lot on female-related issues, but you know what? A whole lot of men are married to women, and there's still a whole lot of women on our channel too. If you don't know that, you should take a look at some of the comments. So here's one of the things. The heart disease in women has tended to be unrecognized. And there are, maybe there's social reasons for it. For example, there's been a lot of focus on things like breast cancer. Breast cancer is obviously very important. I have some friends that have died from, had some friends that died from breast cancer. Good friend of the family died very young in her 40s. But there are also some physiological, some medical reasons why heart attack tends to be ignored in women, even though it's like, what, there are 10 to 30 heart attack deaths among women for every breast cancer death. And it is by far the #1 cause of death in women. So it's the #1 cause of death in women. It's less likely to present as your typical, an elephant's sitting on my chest kind of chest pain, or I've got chest pain and it's going down my arm. In fact, quite often women's symptoms will end up being, you know what, I felt a little emotional, I felt frustrated, things just didn't feel right. I mean, you get these kind of stories and it's very scary. I know I've had some women in my family where, you know, they are maybe sometimes tend not to be as steeped in denial as me and other men, but still had hefty doses of denial. And it becomes very difficult to get them to start saying, you know what? Yeah, you know what? This could be heart attack. So we're going to go a little bit deeper into heart attacks in women and what you should know. Previous topics we've covered, mode RNA vaccine, passing phase 1, going into the next phase of development. There are a couple of other vaccines that are running well out there. The Oxford vaccine, for example. And again, a couple of others. So there's a lot of very interesting, exciting information about that. Repurposing old drugs against COVID-19, we covered that. Stem cells is a possible cure for diabetes. Not so fast, and it's a little bit more complicated than you might think. Check out the video if you're interested. I think our most popular by far topic out of all of the recent past couple of months has been saturated fats. Now, what, good or bad? As you know, we've been, the medical community, our society has been nailing saturated fats as bad for you for not just a couple of months, couple of years, several decades. Saturated fats are bad. Well, when you actually start getting into the science, are they really? JACC, the Journal of the American College of Cardiology, recently did a very good meta-analysis. The meta-analysis was not on case reviews, it was on randomized clinical trials. There's a bunch of randomized clinical trials out there now about saturated fat. Now, guess what? There's not the significant evidence that we thought the saturated fat is bad for you. And we covered that in several different formats. We covered it in a full YouTube live format with questions and answers. We took off and did a short version, and we did a shorter version. All three of them ended up being very popular because this whole topic of saturated fats is a big deal. If there's one topic that dwarfs all of them in terms of our entire channel, and that is reversing plaque. And yes, we had a lot of interest in that. Fiber was popular as well. We've just spent a lot of time talking about how we can improve access for some of the critical information that you usually don't get from your doc. And here's the thing. Most people think, well, I mean, obviously heart attack and stroke are very important. Heart attack's the #1 cause of death. Stroke's the #1 cause of permanent disability. And most people think, well, if I'm worried about a heart attack, I need to go to my doc, and my doc's going to do a cholesterol test and a stress test. Those are the two wrong things to do. Half the people that have a heart attack have a normal cholesterol. So, and just Google false positive, false negative stress test, and the Google snippet from the will come up. It'll be from the NIH, and they'll say, out of about 7 to 8 million stress tests done per year, 1.5 million of those are known false positives and false negatives. What's unfortunate, though, is that we just don't know which ones were false positives and which ones are false negatives. So the state of the art for helping you understand whether or not you have risk for heart attack and stroke is not very good, at least the standards out there. And there is better information. There are better ways to look. You can look at things like a coronary calcium score, a CIMT, which is even better for following long-term. Glucose values, Kraft insulin survey, oral glucose tolerance test, cardiovascular inflammation tests. All of those things are out there and they're available. And actually, that's what we focus on in providing to you in these webinars. One of the things that's been confusing is that you see 449 and you think, doc's got an inflated ego. That's too much to listen to somebody. Well, that's not just listening. The labs are included in that. So we're reconfiguring this so you understand exactly what you're paying us for the webinar and what you're paying to actually get the labs. The book, again, continuing saga. Writing a book's always a nightmare. I understand now why I was so hesitant to jump into that space. We're getting closer. We've gone back and forth in terms of self-publishing versus waiting for a big house and losing control. I think we're going to go the former route, and waiting on Todd to give me an update on where he is. Speaking of the webinars that we have out there, one of the perennially popular topics that we have, people say, you know, what are the best supplements? What can I take? As we all know, you can't supplement your way out of a lifestyle problem. But what most of your docs don't know is that supplements do help. You look at the science and it's clear. Now, not all supplements help for all areas. So I get a lot of people saying, Doc, you've been trained in terms of allopathic medicine. You're trained doctors at Hopkins. Most docs don't understand supplements. You do. What do you take? This is the way to find that out. And the subscription programs, again, have been doing very well. A lot of interest in getting those up and rolling. Speaking of getting up and rolling, we've gotten our new website up and rolling. I never put any time or effort or investment into the website originally. It was obvious. It was ugly, lots of reds and dark colors, clunky in terms of the way it was developed. But it was really meant to be more of a brochure website. It's becoming a little bit more than that these days. It's becoming more of a destination website. We're adding blog information. Go out there and please take a look. We'd appreciate it. Some of the information that's been that's drawn eyeballs, drawn interest in terms of the YouTubes. Now you can actually find that information on the website as well. And it used to be PrevMedHeartRisk.com. It's now PrevMedHealth.com. So tomorrow night, Thursday, July 30th, 7 p.m. Eastern Time, Dr. Doug Thompson will be having an Ask the Doctor YouTube Live, I believe. And here's how you register for the webinar. And Doug has been a very popular presenter on these YouTube Live programs. He's a dentist. He started and still runs the Wellness Dentistry Network. It's a group of hundreds of dentists across the country who recognize and understand that, you know what, unlike your typical dentist who goes in, knows that they're going to see bleeding gums in half of their adults and just focuses on drilling, filling, and billing, these guys actually start looking at those folks that have bleeding gums and saying, you know, that's very related to prediabetes, right? Which is very related to heart attack and stroke, right? So again, a very, very different type of dentist. So we're going to go ahead and get into the program for the day right after Aspen gives us the water ball. So, as I said, women have heart attacks too. It's clearly the #1 cause of death for women, but they're different from men. And in addition, they've typically been ignored. A couple of differences. Men tend to have, as we said before, they have that classic elephant sitting on my chest kind of chest pain. Women often do not get that kind of chest pain. Quite often they get an feeling of agita. Sometimes they just get shortness of breath. Whereas men, again, get that pain that goes down the arm. Quite often with women, you'll see some pain, if you do see pain, and it'll be in the back or up in the jaw. Again, very, very different kind of presentation. Get palpitations, cold sweats, paleness, more of a flu-like symptoms, and anxiety. Chest pain is still the most common symptom. Some chest pains are just not always severe, particularly in women. Women are more likely to have symptoms unrelated, like neck, jaw, shoulder pain, upper back pain, abdominal discomfort, shortness of breath, pain in one or both arms, nausea, vomiting, sweating, lightheadedness, dizziness, unusual fatigue, indigestion. Symptoms may not be as noticeable as the crushing chest pain often associated with heart attacks. This might be because women tend to have blockages not only in the big arteries, but also the smaller ones that still supply blood to the heart, but a smaller area. That's one of the biological differences that we tend to see in heart attacks in women. As I said before, some of this is social, but some of this is biological. Women tend to have symptoms more often when resting or even when sleeping. Emotional stress can play a role in triggering heart attack symptoms in women. And as we mentioned a couple of times earlier, it may be one of the major symptoms of heart attack. Because women don't always recognize their symptoms as those of a heart attack, they tend to show up in emergency rooms after the damage has occurred. And that's the thing. You know, you've got to have a bigger, what's called an index of suspicion among women. As I mentioned earlier, I've done that with a couple of women in my family, and you know, you just sort of feel bad, but it's like, yeah, you know what? I know you just sort of feel bad. I know you don't have exactly chest pain. I know you've got some stuff in your jaw right now and your back. You got to know that this happens among women. So let's go in, get it checked. I know it's embarrassing. I know it's a hassle, but it's a heck of a lot better than finding out the hard way that was a heart attack. Because the symptoms differ from women, they're diagnosed less often with heart disease than men are. So it's not unusual to find a woman who's had these symptoms that have been treated as anxiety, treated as depression, treated as a mental health issue, when it turns out it was heart disease the whole time. As I mentioned earlier, yes, breast cancer is a huge tragedy. It's a huge problem. But most people are unaware that far more women die of heart attack than breast cancer. And I mentioned I'll fact check myself on that. I mentioned 10, maybe 30. It's 7 times more women die of heart disease than breast cancer. Women of all ages should take heart disease seriously. That includes women under 65, especially those with a family history of heart disease. Young women, for example, are classic for getting Wolff-Parkinson-White, some dissection of the arteries, things that I'm not going to explain technically, but they are classically seen among heart problems, heart diseases, classically seen among young women that people just don't think about. So risk factors, number one risk factor, no matter which gender you are, diabetes. Women with diabetes are more likely to develop heart disease than are men with diabetes. And here's the thing, this is basically coverage of an article from Mayo Clinic. I tend to get frustrated with Mayo Clinic sometimes, and this is one of the areas that I would say I've got a slightly different take on that. Yes, if you're a woman with diabetes, you have significant risk. But when we say that, we tend to neglect the bigger population. You don't have to have full-blown diabetes to have significant risk for heart attack, whether you're a woman or a man. And unfortunately, that's one of the bigger continuing misperceptions that we have in our society, both men and women. And they get this from their doctors as well. Well, you know, I've got a touch of sugar, but it's not bad. So I'll just get 1 teaspoon of sugar in my coffee in the morning rather than 2. And that's not the impact at all. If you have any sugar problems at all, you are at risk for building plaque. And if you're at risk for building plaque, if you've built plaque before in your artery walls, that is what creates risk for heart attack, stroke, blindness, you name some of these big killers. Mental stress and depression. Stress and depression affect women's hearts more than men. So they're not only a risk factor, they're also a misdiagnosis as well, a red herring. As I mentioned before, quite often women's occult, unrecognized heart disease actually was called depression, or more often anxiety, for weeks, months, sometimes before it was actually appropriately and correctly diagnosed as heart disease. Smoking is always nuclear. It's nuclear if you're a man or a woman. It's a greater risk factor for heart disease in women than it is in men. Inactivity. Some research has found women to be less active than men. Menopause, the low levels of estrogen after menopause pose a significant risk of developing disease, especially in those smaller vessels that we mentioned earlier, where women are a little bit more, they're at more risk for having a heart attack in the smaller vessels of the artery. And sometimes, again, that may be leading to not so much the classic symptoms of the elephant sitting on your chest. Pregnancy complications. High blood pressure or diabetes during pregnancy clearly increases the mother's long-term risk of high blood pressure and diabetes. And if you're talking about diabetes during pregnancy, think about this. Not only is it a sign that the mother's going to have heart attack and stroke because of early diabetes and prediabetes, it's also a risk factor for the child. If the child is born at over 8.5 pounds, much greater risk for having prediabetes and diabetes as they grow older. We're talking 50 years later, 60 years later. I'm one of those kids. I was born at 10.5 pounds, and despite the fact of having a BMI in the low 20s, typically 21, 22, still had significant prediabetes starting in my mid-50s. Family history of early heart disease. This appears to be a greater risk factor in women than men as well. So some of these things with Lp(a) or FH, or again, smoking, some of the things that, again, early risk, early family risk. Inflammatory diseases, rheumatoid arthritis. I saw a patient yesterday who, for the most part, appeared to have a lot of his risk factors in in control. Except one of the things that we were looking at was, in fact, it appeared that he may have had some significant carb problems. He was getting his arms around those. But one of the things we began to see was he continuing to grow plaque? And then one of the things we found out, I said, is there rheumatoid arthritis in your family? He said, yep. My mom and her sister both have significant rheumatoid arthritis. Why am I focusing on rheumatoid arthritis? Because if you have it, it's as much a risk factor as diabetes. Now, why don't you hear about rheumatoid arthritis and the other inflammatory arthritides? Pardon the use of that term, a big sounding term, arthritises. You don't hear about rheumatoid arthritis and the other inflammatory arthritises or arthritides being a risk factor for heart disease simply because they're not so common. When you have a half to 2/3 of an adult population over a certain age with prediabetes, you just don't have that many people with rheumatoid arthritis. So population-wide, diabetes is a far bigger killer. However, if you have rheumatoid arthritis, be afraid, be very afraid. Make sure that you do everything you can to manage that inflammatory process. We don't know whether it's a crossover. We do know that rheumatoid arthritis, that's the arthritis, by the way. It's not that, oh, I've got a knee problem or, oh, I've got a joint problem here. When you see people that are crippled with arthritis and they have what we call ulnar deviation, this is the ulna, this is the radius, and you have ulnar deviation of the fingers. That's the arthritis that we're talking about. That happens because there is a cross reaction between the immune system and some of the proteins in the joints themselves. Now, is that cross reactivity causing an immune cross reaction to the plaque? We don't know that. Is it just the fact that we've got the byproducts of inflammatory processes going on, like the things we've called before, the cytokines, the things that amp up further inflammatory processes? Is that what's causing the increased risk in people with rheumatoid arthritis or lupus? We don't know that. But what we do know is that those diseases are a significant increase in risk for heart attack and stroke. So, again, this gets to some of the basics. What do you do? Well, if you smoke, stop. If you eat food, make sure it's healthy food. Know whether or not you have insulin resistance. Get an OGTT, a Kraft insulin survey. Get a CIMT. Get a calcium score. Manage your stress. Limit alcohol. Exercise regularly. There's a reason why so much science tends to focus on 150 minutes a week of aerobic activity and 75 minutes of vigorous activity, or a combination of the two. If you look at those of us whose insulin receptors in our muscles and our liver are getting rusty and resistant to insulin, we bypass those insulin receptors entirely when we exercise. Exercise actually has an insulin effect. Those of you who have used the Libre and you go out, you have a beer or a pizza or both, you take a carb vacation, just a gentle walk for 20 minutes will take the top right off of that carb spike, that blood glucose spike. So here's the thing. If you get large enough muscles and intense enough work, you'll get an insulin effect for up to 48 hours. Now, does that help you begin to place this science showing probably at least 2 days a week, significant exercise? 48 hours of insulin effect, at least, not 2 days a week, every other day, 3 times per week. So does that help you draw some connections there between why exercise is so helpful for heart attack and stroke prevention. Obviously, maintaining a healthy weight. I don't think from what I do, from the patients I've seen, from the work I've done in this space, I don't think there's anything more important than managing your body fat. Consider developing a healthy weight. Keep a BMI usually in the low 20s. There are people with a Schwarzenegger effect. They have a larger BMI, but still a low body fat. But just think about it. Arnold Schwarzenegger, when he won Mr. Olympia, had a BMI of 30. So if you look, so you probably have a healthy body fat content, even at 30, if you look like Arnold Schwarzenegger did when he won the Mr. Olympia. Otherwise, especially, this is a tendency among men. I've got a lot of big muscles. The BMI doesn't cover that. Adjust your BMI by your waist size. If it's 35, 34, you need to be thinking. So follow treatment plans. In general, heart disease treatment in men and women tends to be similar. Low dose aspirin is prescribed. You know, there was a couple of articles that came out, studies that came out. One of them was called the Esprit trial, just about a year and a half ago. And those studies threw this whole question of preventive aspirin into question again. And here was the bottom line on it. I covered it. If you want to look at aspirin, preventive aspirin, we've got a couple of videos that go way deep into those studies. The bottom line, though, is this. If I have plaque, or if you have plaque, I recommend you have some sort of blood thinner. And if you're not on something else already, like Eliquis or rivaroxaban, Xarelto, one of those for atrial fib, then you need to be on aspirin if you have plaque. If you don't have plaque in your artery walls, then you don't need to be worried about that. How do you know if you have plaque? A stress test is not going to tell you that. So, Aspen, you want to go ahead and hit the video?
For decades, heart disease was considered a man's disease. But what many people don't realize is that each year, heart disease kills more women than men. And because of this misperception, women with heart issues sometimes don't get the diagnoses or care that they need. Let's go to Mayo Clinic, where doctors are trying to change that.
Well, actually, I didn't know I had any heart problems until I had my heart attack.
But Sharon Fellerson, who was adopted as a child, did know that her birth mother had heart trouble.
She ended up with 2 heart attacks and a 6 bypass.
So with a family history like that, why didn't Sharon realize she was at risk? One reason could be that for decades, heart disease was considered a man's disease. The truth is, heart disease is the #1 killer of both men and women. 1 out of 4 women will die of heart disease. But research shows that men tend to do a whole lot better when it comes to diagnosis and treatment.
Women tend to be diagnosed later in the course of their disease. And once they do get diagnosed, they tend to do more poorly than men in their outcomes.
There are several reasons for this. Doctors may not be vigilant about treating risk factors for women. Women may have different responses to treatment than men. And some women, like Sharon, simply don't realize they're at risk.
The biggest message is that women should be talking to their doctor, their primary care doctor, about what they can do to prevent heart disease, what signs and symptoms they should be aware of.
Women should know that not all heart attacks cause chest pain. Other symptoms include pain that radiates to your jaw, shoulder, or arm, nausea, vomiting, and intense sweating. If you have symptoms or any chest discomfort that just doesn't go away, call 911.
Better safe than dead.
Dr. Hayes says there is currently much research underway to determine why women don't do as well as men and what can be done about it. She also says things are improving because more women and their doctors are learning about the realities of women and heart disease. For Medical Edge, I'm Vivian Williams.
So thank you, Aspen. I've been looking at the comments. We've been getting a lot of comments about heart heart screening programs. Dave Murphy started off with a good morning and his O2 sat and his beats per minute. Dave, those are both very good. After losing 135 pounds, it makes it a lot easier for your body, for your engine to run, doesn't it? Good morning, Bart Robinson. Coronary artery calcium score and CCTA slated for tomorrow. Dave, let's not go into that giant headache I caused you on the CCTA, the CT angiogram. In fact, we'll talk about what that is in just a minute. Still working on CIMT, scheduling locally, hopefully in the next month. And here's where we go. So James Cantor's saying, what's the CCTA? Well, coronary CT angiogram. So if you look at the three things I would recommend, go back and look at our video on 8 ways to detect plaque. One is the Framingham survey, which is not a test, it's not a detection, it's an estimate, and it's a bad estimate at that. And we can go into some details on that if you want. It actually overpredicts risk and is probably one of the major reasons that too many people are on statins these days. You get a somewhat risky Framingham, and then the doc says, you know what, maybe we should do a stress test. Here we go down that road. As I mentioned before, about 30% of stress tests, 20 to 30% known false positives, false negatives. The problem is we just don't know which ones are known. Stress test is only going to be positive if you have 50% flow occlusion or more. And 2/3 of heart attacks occur with less than 50% flow occlusion. So another problem with stress test is a way to detect plaque. Then you get a false positive or you get a false negative stress test. Unfortunately, you think you're fine. You get a false positive, you go to the cath lab. And in the cath lab, we know where that goes. So there are better ways of doing this. Number one, coronary artery calcium score, CACS. Somebody asked, what kind of technology is that? Is it ultrasound or X-ray? It's X-ray. It's actually a CT technology. Then it's good at detecting calcium, but it doesn't look at soft plaque very well. Soft plaque is the real risk area, and that's better done with CIMT, coronary carotid intima media thickness test. That's the one that they do in the artery in the neck, the carotid artery. The problem with that one, it's much better for looking at what the real risk is with soft plaque. It's much better for doing follow-up on a regular basis. The problem, though, is that it takes meticulous, I would say obsessive compulsive focus on exactly where did I go in, what was the angle, both this way and that way. There's a major focus on getting it exactly repetitive. And you don't get a lot of that because people don't understand how to do the test that well. So then you end up getting a lot of garbage in, garbage out. So, but the third one I had not mentioned yet, and that is CTA, CT angiogram. Basically, they inject dye and then they start taking pictures, and you get 3D pictures of what's going on in the arteries of your heart. Now, you can say, well, we get a little bit of image of soft versus hard. Not really, not practically. One of the other questions is, how about invasive? Well, it's not like having you on the table and going up through your groin with a catheter, but what they do is inject dye into the vein and then start taking pictures of radioactive dye as it goes through your heart, the arteries of your heart. So I hope that's a helpful bunny trail on CT angiogram and what it's about. The CT angiogram in studies like the Scott Hart, I've got videos on those. Take a look at those. Scott Hart basically are showing that, you know what, assuming your doc is one of those 98%, 99% that are old school, still want to do a Framingham and a stress test, just ask them to at least add a CT angiogram. Even that group, that 98, 99%, are starting to agree, yes, CT angiogram helps. And the bottom line is you end up being less likely to be dead 5 years later if you had the CT angiogram. Now, why is that? Do they help you quantify? Actually, what they do is they help you realize that, I had a negative stress test. On the other hand, though, I've got a lot of plaque in my artery. So every time I go to the refrigerator to eat Twinkies or whatever, I've got problems in my arteries. I need to be slowing down and changing my lifestyle. So is that invasive? So that was the answer to that. No. So good luck, Dave. I would agree. Thanks, and I would agree, Dave. Good luck. And so here's what happened. Dave wanted to get those, and yes, we use those. I have not ordered a whole lot of them just because I'm usually using CIMT an occasion. Well, it looks like my camera was unplugged. Let me go back and see if I can. Why did that happen? Hold on. Well, I think we'll do the rest of this without looking at my face, because we've got two cameras, the webcam and the Canon. Both are working, but the software is not picking them up. Anyhow, just a couple of other points, and we'll go ahead and finish it out. The CIMT is an ultrasound technology. Coronary artery calcium is X-ray, as we mentioned before. Yes, Dave, you're right. It's X-ray. Anyhow, what I was going to say is I made it very difficult in terms of the coding process on the ordering for Dave. Dave was very, very patient with me, and thank you again, Dave, for your patience. Robert Simpson, have you heard of a personal EKG that works on your smartphone called Cardia Mobile? Robert, yes. Go to my videos and look up iCardia, little I, large K, ARDIA. I did a series of about half a dozen videos on iCardia and its competitors. One of those competitors is now the Apple Watch with cardiac screening on it. And I will also add in one of those videos, I go through the details of how I confirmed my own diagnosis of atrial fib. I had suspected for about 3 years that I had atrial fib, but I was one of those people where I was pretty sure it was, most people would call it occult atrial fib, which is incredibly common. And guess what? I did. It was very clear. I woke up, I felt like had a fish jumping in my chest. I had an irregular rhythm. Rate was about 120 to 160. I had atrial fib. So we've got several people that have atrial fib. Oh, we've got a couple of great, thank you so much, Dave. $5 for another great subject. Look forward to sharing it with my circle of friends. Greg Without Diabetes shared $50. Thank you so much, Greg. We really appreciate these super chats. I don't draw an income from the channel. In fact, I do see patients associated with the channel, and that money goes back into this channel. It goes into paying our staff, Aspen, Carl, Michelle, others, and it means so much to me when somebody else says, you know what, I'm going to contribute some of my own bucks to get these life-saving facts out to the public. Thank you so much. So James Cantor, hi everyone, check if you like. Yes, indeed. More excellent info as always. Smash the likes, folks. Thank you, John. And again, thank you, Greg Without Diabetes. Doc Brewer, thanks for the CIMT conversation that we had the other day. You're very, very welcome, Greg. I greatly appreciated your interest. Still do. CC and the super chat button donation. Thank you again. That'll, you know, a lot of our staff, everybody except Michelle, Janice, and myself are from the Philippines. So it's on a very different kind of monetary scale. That $50 will pay a couple of people's salary. A couple of people that have worked with us, it'll pay their salary for almost a week. It's a big deal. Get us almost a week worth of video editing and some other very critical functions. Dave Murphy, CCTA, the CT angiogram offered both with and without flow. The flow is significantly more expensive, 600%. I don't really think it is. I think the best thing is to go ahead and get a picture of those, that plaque. And here's the reason for it. We all keep talking about flow. You know, the the stress test is a flow study. And flow studies tend to focus on, well, do you have 50% or more impact on your flow? You don't have to have that. In fact, as we said before, tiny amounts of impact on the flow can still confer significant risk. It's not the loss of flow that creates risk. What creates the risk is having the plaque. And once you know anatomically, I've got plaque in there, it helps you understand, I'm not out of jail free. I do have to watch my carbs. I do have to exercise. I do have to watch my stress. I do have to take my medication. So again, maybe I got a little bit repetitive there. Amer Algayer, hi from Germany. Hello, Amer. Thank you for joining us from Germany. John Tocho, and you can join Patreon. Thank you so much, John. I do appreciate that. We do have Patreon account on there. Let me see, Aspen, if you've got that image up, maybe you could show the Patreon real quick before we jump off. There you go. Thanks so much. So as you see here, there are several ways to donate. You can do a super chat, as Dave and Greg Without Diabetes did. That's here. PayPal, we have a PayPal donation account, and donation through Patreon. That's what John Tocho was talking about. Just look us up and we'd appreciate it. Thank you so much. Speaking of appreciation, I appreciate your interest on the video today.